My name is Dr. Emma Stratton. I'm a consultant geriatrician, and I'm here to talk about how we've involved a lot of the elderly and recruited a lot of patients into the COVID ward-based trials here at UHBW, but also to encourage you that anybody can be involved in research and how I have got involved in it because of this pandemic. So where it all started, at the start of the spring in 2020, I was working for the Great Western Hospital. One of my care of the elderly wards was one of the first wards to swing to receive the first COVID patients of 2020. Soon, in the months that followed, the recovery trial opened, and we were approached by the research team that whether we would get involved in the recovery trial. Now, before the COVID pandemic, I'd done my GCP training, had screened a couple of patients for an eligibility trial, for some stroke trials as a registrar, and been on a research day for part of my curriculum tick-off on the way to CCT. And I'd done very little research on the run-up before the pandemic. But here we were seeing a virus that was affecting many a patient and spreading rapidly and was new, and we had very little treatments for this at this time, and was keen to be involved with the patients that we were looking after of the elderly population to ensure that everybody got the opportunity for the trial. As a geriatrician, we will be aware that many of the trials that we see will exclude the older adult as part of the exclusion criteria, or will have exclusion criteria that mean that most of our elderly patients aren't eligible. And this trial was not that. This trial and Heal COVID were pragmatic and encompassing all, and therefore it was important to make sure we didn't miss that opportunity. Later on in the pandemic, I was to move to the UHBW in September 2020, and I took with me my experience of being involved in the recovery trial and approaching the patients of the elderly to embrace following on with that research at there. I wanted to make sure that we gave patients the opportunity to be involved. Part of the barriers I first experienced was some of our own biases that we had. Oh, that patient's too old, or that patient's too frail. And actually, when you gave the patients the information to read about the trials, that most patients were interested. So the NHR has the B part of research, which has a link now to give out to the public to say, I want to be involved in research. The public are interested, and particularly in those first few waves of COVID when the treatments were limited, patients were interested to take part, hopeful that the treatments that they might be randomized to may improve their benefit. But particularly of the elderly population that we were approaching for the trials, they were really keen to find answers for the future generation, for their children, for their grandchildren, some of who were also very unwell with the virus. So the first barrier that was some of what we were putting, whether we were kind of screening those patients and thinking whether they were eligible or not. Because of age, and that's really important to recognize our own biases within ourselves. The move brought new opportunities. I expressed my interest, as you do, of being involved in the COVID research trials that was led by a trialist and a researcher in surgical medicine. And this wonderful team depicted here are the surgical research nurse team that led the ward-based COVID trials at UHBW. And I joined them with my colleague, Dr. Jan Willis, who was an acute medic at the time, consultant, in co-chairing the ward-based approach for the COVID research. Now, this saw many a patient recruited, as we'll show later on, with our peak in January 21. But this comes with challenges as well, particularly of our elderly patients that can take some more time and have more complexities when we're thinking about approaching them for the trial. But I was very keen that those patients weren't missed. And if we were time limited, we weren't adding confounders by kind of almost selecting the patients that we had the time to recruit. We'll talk more about how the team-based approach helped with our recruitment, and how I would suggest and make recommendations to other teams on the call about to help with your recruitment going forward. And then came the opportunity for Heal COVID. We were interested that as the waves went on with COVID and we saw different presentations in the phenotypes of our patients, that we were starting to have treatments that we could use with our patients via the recovery trial and the inpatients, but there was no treatment and research into the long COVID effects of the patients that we were seeing being readmitted into hospital after the incident COVID admission. And so we embraced when Heal COVID came along to be involved in that, registered across sites, and we were one of the first sites to have recruitments back in the June when it only opened in May, and that continues going forward. But there have been challenges as we approach the elderly. As we said about time constraints, when we had large waves at our sites in Bristol, we had hundreds of patients to screen each day for eligibility. Um, and we have to think about how best to use the time. And how we did this is that, as our geriatrician approach, no man or woman is an island. You work together as part of an MDT. And that's the approach that Joe and I took, that to meet the vast numbers of patients that would need screening, eligibility, have eyes on the ground and advocates, we needed an army of trainee doctors, an army of AHPs, an army of nurses to advocate for them. And that way we would have the time to ensure that everybody was screened and eligible, and nobody was not deemed eligible because we didn't have the time to speak to relatives or read pills to patients without glasses. And that took a vast amount of resources, and we were lucky that we were able to engage via teaching sessions to the different departments, to the amazing departments and colleagues that we've worked with, many of whom of my care of the elderly colleagues who are joining this presentation today to support me, and I thank them for that. But there are extra challenges of our multi-morbid older patients. Some of the patients had cognitive impairment. Some of those patients, when we screened and went for a capacity of as we remember, as a decision-specific, time-specific assessment, did not have the capacity to look into being able to participate in these trials. And we needed to look at legal representative consent, or professional consent with the absence of our legal representative when visitings were restricted. We had patients with sensory impairment, patients who were hearing impaired, patients who were visually impaired, and again, with the limitations of the visiting and next of kin, this brought the challenges that there might be relatives too unwell to bring in the reading glasses that they needed to read the patient information leaflets themselves. And it took extra time, but we read the patient leaflets to the patients witnessed by somebody else to give them the opportunity, whether they wanted to take part in these trials and continue to take part in trials such as Heal and Recovery. And we might spend some hours doing this and a patient say no, and somebody that would witness and say, oh, do you know, you've spent all that time reading that information to a patient, asking the questions, and they've not signed up. Don't you feel disappointed? And our reply was like, no, our job is to give people the opportunity. Our job is to have the interest and for them to make the decisions. And if they've made a fully informed choice to say no, then our job is done. Obviously, we'd like them to recruit, but we are realistic that not all will. And then further limitations have been because of the lack of visitors, that particularly in the waves where visiting was so limited, that you had relatives who were frightened about loved ones being experimented on in their eyes, who normally would have come in, chatted over, looked at the paperwork together, and felt separated from loved ones. And the ways we approached that, which is now easier with the relaxation and visiting of relatives, was we had many a phone call. We emailed the pills that were available on the Heal website and the Recovery websites to loved ones all around the world, so that they could read the information themselves, they could speak to loved ones over the phone and help support their loved ones and next of kin with these decisions. We also had FaceTime conversations, FaceTime with important loved ones to the patient, um, FaceTime conversations with people who are important in their lives, involving imams, if that's in some particular cases, as they wanted them to be involved in the patient's decision making and wanted us to explain to them over FaceTime with the patient involved. So there were many challenges to circumvent, but there were ways round it. And as I said, the time and resources that we were lucky with the number of junior doctors, AHPs, and nurses who were willing to support to look for the answers for the Hill COVID research. And the last challenge that we have now is medication. Medication mainly in Hill COVID. So a lot of our patients are already on the medication arms that all those on the call will be all too familiar of apixaban and statins. But also thinking about the patients, are they suitable for these medications? You know, are they an elderly patient that's falling? And we have to think to ourselves that are they patients that we would normally be starting apixaban for other reasons in, or normally starting simvastatin for other reason? If the answer obviously for that is no, then that we need to think not just the black and whiteness of the eligibility form. And that's where it's really important, because often it's these patients that are complex that you're having to think a bit more about their involvement in the trials. It's important to involve the geriatrician who are looking after many patients who are already on these medications and are used to seeing the frailty, multimorbidity of patients who already take these medications day in, day out. Because it was really important, as Emily Henderson and team showed in their quick review of the patients of the COVID trials, it's really important to engage our elderly patients in these trials. We knew from the waves earlier on that the older patients were affected more and had higher mortality, but also to think about how the older patient presents. So we look at the eligibility of Hill COVID, that the patients are symptomatic from the COVID. And we were finding that patients not necessarily screened with the input of a geriatrician, maybe be put down as incidental. But the elderly, as time went on with the waves that we have, do not present typically. And even in those first waves, were not presenting typically, presenting with falls, presenting with delirium, presenting with posture instability, presenting with diarrhea and GI side effects, present some without a fever, but then with the oxygen requirements and pneumonitis. We needed to think more broadly about, was this COVID causing their presentation, and therefore did we want to involve them in the trials rather than missing those just with the respiratory symptoms, and that was important as well. So as I said, we needed teamwork. We needed teamwork going forward. And how did we do this? We're often asked about our site, about how we have managed with our recruitment of large numbers, but we work as a team. We work as a multidisciplinary team with nurses, PAs, trainees from F1s through to registrars and consultants. We have consultant colleagues who have done the training that not want to be involved as delegates, but want to keep up to date with the training arms to be able to offer to their patients. We have a screening list that is coordinated by our research nurses and sent out to all the delegates on the training log. And we keep up to date via WhatsApp communication where no confidential information is shared, but would highlight, I'm off to screen so and so, I'm off to screen so and so ward to see the patient, so people didn't duplicate work and people knew that areas were covered. This is more important when we are covering large numbers of wards and large numbers of patients, but it's still important now when the numbers are smaller to make sure nobody is missed. And we have the benefit of the APIs for that, which are massively helpful. And if you are a site that doesn't yet have APIs, I would really encourage the APIs. And we'll discuss that in more detail. So our communication now means that the APIs who we have for recovery and heal will work together, and they will help support each other if they are on leave or on days that they will go and see the recovery patients and heal, and the vice versa. So all are offered the opportunity. And as you can see, we had good recruitment numbers in the trials. In the first few waves, we recruited to recovery, remap cap, and these are the ward based. We weren't in reaching into ITU. We had our own research team for the team that went to the remap cap of ITU, and tactic R. And this brings me on to APIs. So there's been some research done the API scheme via the Sunflower trial that shows the real benefit to APIs, not only to the APIs personally, with some of them going on to further develop their research careers, including one of our APIs depicted here as a result of the API scheme, but also benefits the local site recruitment and the overall trial recruitment. It's a structured approach with mentorship via the PI to give them the tools and skills to hopefully want to be the PIs of the future. So we've had 4 APIs who have completed it via the HEAL COVID scheme, 2 of which have been physicians associates, which have been invaluable members of our team and the stability. But also 3 of these past APIs and all 3 of my current APIs are within care of the elderly. And this also helps because, as I said, with each wave, the phenotype of the wave is changing. And we are seeing many more of the patients that present atypically of the older patient with those deliriums, with those posh hypertensions, maybe without fever but respiratory symptoms. And therefore, we need the eyes and the ears of the ground to highlight these patients to the research team of potential eligibility to these trials. The APIs are incredibly helpful because not only do they get the structured training and support as part of the trial. They help the trial site in the recruitment, as with each wave, the clinical activity went back to how it was pre-COVID, where the clinics weren't cancelled. We were going back to cancel clinics and didn't have that other clinical activity that was cancelled on side, and therefore our time is pulled in more directions. That they are able to have the time to focus on the patients and make sure patients are not missed, or if more complex as already described, can give them the time and talking to relatives, patients, um, perhaps legal representative consent or professional consent going forward. So how is it going on our site? As I said, we are now having smaller numbers coming through, but we are still actively recruiting for our patients of Hill COVID. We're a split site with a larger tertiary centre based in the city and a smaller DDH site based out towards the sea and Weston Supermare, which is a small site of only 250 beds. But we have APIs on both sites because myself as a PI can't physically be in both sites, but can obviously discuss over the phone, over email with the APIs on both sites to help keep the recruitment going. And although we've not seen many numbers over the last few months, we continue to recruit using this team-based approach, but also making sure that as well as the APIs, every delegate is thanked for their support. And so at the end of each rotation before July and August, we have a letter of thanks from our research team based at the university and every delegate who has been involved in the recruitment, screening, consent, randomization, i.e more than just doing the training online for recovery or heal, will get a letter for their portfolios, for their CVs, going forward as a letter of thanks. And as a because without them and without the army of collaborators who've recruited, we could not do this going forward. And that's what I think I've brought to this trial as a geriatrician, that we are not an island. We work together as a team, and to do that has helped us recruit well and has helped us have the time and the resources to make sure those patients who are older have had the opportunity to be involved. And this just summarises how we're going so far. So we are registered as 2 different sites on the newsletters, but we are one trust. And we've recruited 118 so far. And as Mark has already said today, we stand at the total recruitment in the Hill COVID nationally as 1,190. So I'm incredibly proud of what our team has achieved. So my key messages going forward is research is everybody's responsibility. But if you are like on this call like me and you didn't do much research before as a trainee or in your lead up to CCT, or perhaps since now as working as a nurse, an AHP, a consultant, then it's never too late for anybody to get involved in research. There's an amazing team within each hospital of researchers, and they will support you and they will handhold you when you don't know how to randomize and you don't know how to use Edge and you don't know that you need to initial each statement on a patient initiating form. They are there to support you. And you might just find you really enjoy it because you really enjoy involved in the patients that you really care for and specialize to in your day-to-day life. Hopefully, it's come across that clear leadership from our senior research team has enabled us as a trust to increase our recruitment by the involvement of many on the ground in each ward when we had high numbers, and we continue in this approach to make sure that all get the opportunity to be approached. we I encourage you that if you have the older multi-morbid patient, to ask your geriatrician colleagues for a second opinion about whether they've been involved. When we've recruited over the time patients who are very well known to teams, maybe being under haematologists for years, perhaps been under a cystic fibrosis team for decades, we've although the patient may have met all the eligibility criteria on paper, we've always involved the teams that have been looking after them for their thoughts. And often the patient would say, have you run it past my haematology team? So this is no different. Run it past your specialist care of the elderly team. If you're already thinking about somebody involvement but are unsure, ask your geriatrician colleagues. They'd be more than happy to help. They want to see more of our older patients involved in trials that aren't excluded from age or for comorbidities. And this is just one of them. And it'd be great to see the patients that are affected more by mortality and morbidity involved in these trials. And from a staff development perspective, the API scheme is a wonderful way forward and has developed and furthered the careers of one of particularly of our APIs who's going on for a research consultant job in the next few months. I'd like to thank the many people that have helped us. For Professor Jane Blaseby, obviously set up with the trials initially of recovery with Natalie Blanco, for Jove working with me and Jeremy for Remap Cap, but also for the research team at Swindon who ignited my like for research, and for the COVID pandemic, because I don't think I'd be involved or be a PI of this trial going forward if it hadn't been for COVID. So every silver lining. Thank you for listening.